All right. Thanks, everybody, for coming. For those of you who don't know, I think most of you probably do, I'm Eric Marsh. I'm one of the orthopedic surgeons here in Rutland, work across the street over at VOC, and then do all my operating here at RRMC. Today I'm going to be talking about something that I've been doing since November of 2011, so what, about 15 months or so. It's called Anterior Approach Total Hip Arthroplasty. We're going to talk a little bit about what is total hip arthroplasty, why do we do it, what are the indications for it. I'm going to talk a little bit about some of the pros and cons of anterior approach total hip arthroplasty versus other approaches for hip replacement, and what some of the pros and cons are, why certain people choose to do it through different approaches. And then finally I'm going to talk about specifically why I think anterior approach is a good idea, how it changes post-op recovery, what I'm able to do intraoperatively that I think is really a good thing and a good reason to use the anterior approach. So talking first about the hip anatomy, the hip is a ball and socket joint. It connects the femur to the pelvis. It is lined by articular cartilage. Articular cartilage is very smooth. It is a very low friction surface. The books will talk about the amount of friction between two surfaces, opposing surfaces of articular cartilage, has less friction than ice rubbing against ice, so it's a very impressive surface with very low friction. Unfortunately, it doesn't always last as long as we want it to. The hip joint is obviously supported and crossed by multiple muscles and ligaments that help move that joint and give it support and strength. The hip also has a cartilage rim around it, almost like a gasket, to help kind of form a seal right around the joint. It sits right on the edge of the acetabulum, and that's called the labrum. What is arthritis? Basically, arthritis is loss of the articular cartilage. It can be from many reasons. The most common is just kind of normal wear and tear or osteoarthritis, that as we get older, that cartilage just starts to wear out. That's what osteoarthritis is. Previous injuries or surgeries can cause damage to that articular cartilage. Inflammation or inflammatory arthritis. There are multiple different types of inflammatory arthritis. The most common one is rheumatoid arthritis, but there are multiple other different types of inflammatory arthritis that can attack or break down that cartilage, or abnormal alignment. So in hips specifically, something that we call developmental dysplasia, where the hip socket doesn't form as deep as it should, and that just creates abnormal stresses or forces across the hip joint that can make the cartilage wear out sooner. Unfortunately, once that cartilage is injured or is worn out, there's no way to make it grow back. We can't put new cells in there that are going to make new articular cartilage. There are certainly some new procedures where people are doing to try to restore articular cartilage in different joints. None of them has proven long-term to be terribly successful. People always ask me about stem cells and things like that. Can't you just grow new cartilage? At this point, we really can't do that with any predictability or reliability. So unfortunately, once the cartilage is gone, it's gone for good. What else can cause the hip pain? Well, the most common thing other than hip arthritis that I probably see people for is bursitis. And what a bursa is all throughout our body, at all of our joints, everywhere where things are moving relative to each other, we have these bursas. And typically to patients, I'll describe the one over the elbow. So right over the tip of the elbow, the skin is right underneath the bone there. And when you bend and straighten your elbow, you don't want your skin to stick to that bone. So you've got a bursa there, and that's called your olecranon bursa. Well, we've got bursas everywhere in our wrist, our shoulder, our hips, our knees, our spine. And if that bursa gets irritated or inflamed, it can be painful. And so very often I'll see people with inflammation of this greater trochanteric bursa, which is right on the side of the hip. It's a very common thing. Typically is going to get better with some physical therapy, maybe a cortisone shot. But that is not arthritis. That's not something that's going to get better with a hip replacement. The other thing that can mimic hip arthritis or hip pain is arthritis in the back. So what we call spinal stenosis, or narrowing of that spinal cord, where the nerves in the lower part of the spinal cord start to get pinched those nerves, if those are nerves that kind of then go out and are in the area of the hip, your brain will interpret that pain signal as coming from the hip, even though the problem is actually in the back. So differentiating bursitis from back pain from arthritis is a big part of trying to figure out who is going to benefit from hip replacement. We'll get to hip replacement here in a second. One of the things that I always tell my patients is the good news about arthritis is it's not bad for you. It's not going to turn into cancer or give you a heart attack or a stroke or any of those bad things, but it causes pain. And I already mentioned that we can't really fix the arthritis. We can't make the cartilage grow back. So the treatment for arthritis is aimed at relieving the pain. And so we do that with many things, with anti-inflammatories, with Tylenol. We encourage people to lose weight if they're overweight. Physical therapy can sometimes help. Sometimes we will try cortisone injections and things like that. And so what we really try to do, excuse me, in the treatment of arthritis is maximize all of the non-operative treatments, because the operative treatment, what we're going to talk mostly about, although it works the vast majority of the time, it doesn't work every time. There are potential complications, there are risks, there are problems with surgery. So we really try to leave hip replacement as the treatment of last resort. Because once you go from having a hip that looks like this to having a hip that looks like that, you can't ever put that one back in. You can't go back and ask for a do-over. You've got that hip, and that's what you have. So we really try to maximize those non-operative treatments before we get to hip replacement. When we get there, though, what we do, like I said, is we remove some of that bone and we replace it with metal and plastic. So we go in there and cut off the head and make a resection of the bone right there. And then we put this metal piece that goes down into the femoral canal. We hollow out the canal, and there's a ball on top of that. And then in the socket, we kind of hollow out the acetabulum, hollow out the socket, and put a metal piece in there that's got a piece of plastic that sits inside. And what you end up with, I've got a couple different pieces. These don't all necessarily fit perfectly together, but on the socket side, you've got this piece, and that sits right up into that acetabular socket. It's got a roughened surface or a roughened coating, and the bone actually grows into those little nooks and crannies to hold this in place. You can see there are some holes in there. And so what we'll do when we first put it in is we may or may not put a couple screws in there to help make it more stable for that first 6 weeks until the bone can heal into it and grow into those little holes. And then you get a piece of plastic that fits in there and snaps into place. And so you've got that piece on the socket side. And then on the femur, the one that I use looks just like this. And you can see it's pretty skinny front to back, a little bit wider side to side. And the top part is also covered with this roughened coating. And you can see it's a little bit different than the one that I have up there on the screen. That one's kind of long and straight. That one, if you look at it from the side, is actually round. An implant that's shaped like that, for what I do with an anterior approach, would be very difficult to put in. There are advantages to one that's kind of shaped like this. It's a little bit shorter, a little bit narrower, that allows me to put it in through this anterior approach. So we'll talk about that in a little bit, kind of what some of the limitations are of the anterior approach. And certain types of femurs aren't going to be able to, this isn't going to be able to fit all femurs. And so if an implant like this wouldn't work, then the anterior approach may not work. But then on the top of this is a ball is going to sit on there. This one happens to be a ceramic ball. I will often use a ceramic ball in young and active patients because that ceramic is actually a little bit harder than the stainless steel ball, which is the other option. The reason that's important is if something gets in the joint, or there's a little bone fragment that's in there, or the ball gets scratched when we're kind of putting things in or something like that, the ceramic is actually a little bit harder. It's a little bit tougher than the stainless steel. And if that stainless steel ball gets a little nick or a groove in there, it's no longer perfectly smooth. And then as it's rubbing against this plastic, it may wear it out sooner. Now the risk of that's pretty small, but if you're putting a hip replacement in somebody who's in their 40s or 50s and you want this to last as absolutely long as possible, I will often use a ceramic ball like this. It is quite a bit more expensive, but in the younger active patients, I think it's probably worth that expense in order to maximize the longevity of the plastic. But basically, this becomes then the new hip, and now the size of this ball actually doesn't fit in that plastic. That's why we have this one. So you can see that that ball fits right there in that plastic and moves around, and that becomes the new hip. So all the motion is between these metal or ceramic and plastic parts. And so it gets rid of the pain that the person was having from the arthritis. So the success of this procedure depends on a lot of things. First of all, it depends on the fact that the orthopedic surgeon does their job well. And number one, picks the right patient, picks a patient who is having pain from hip arthritis. If somebody comes in to see me and they have hip arthritis, but their pain, most of their pain is coming from arthritis in their back and spinal stenosis, if I do a hip replacement on them, even if I do a perfect job, I'm not going to make it any better because I haven't fixed their problem. So you've got to pick the right patient who actually needs the procedure first of all. The second thing it's going to depend on is accurate placement and sizing of the implants. And so you can see this picture on the top. Fortunately, that's not a hip replacement that I put in initially, but I've helped to care for this patient when she came in with her hip looking like this. And you can see that the ball is no longer in the socket. And that can happen for many reasons. The thing that we control is if we put the parts in the most optimal way to minimize the risk of that. And I'm going to talk a little bit later and show you how I feel like I can optimize that with the anterior approach using this OR table up here. But the standard approaches, excuse me, are done with a patient lying on their side. And so for us to figure out where their pelvis is in space and how we're putting these parts in can be difficult if that patient moves or shifts underneath the drapes once the surgery is started. So if we look at and compare these two x-rays, and you look at what we call how vertical that cup is. So if you draw a horizontal line across the pelvis and then measure that angle of how vertical that cup is versus this one. And now it's a little tough to tell because the pelvis on the top is a little bit rotated, so it's not perfectly square to the x-ray. But you can see that this cup is a little bit flatter, a little bit what we call more horizontal. And what that allows for is a little bit more coverage of the ball with that kind of edge of the socket, as opposed to if that cup were sitting kind of more up and down, that hip socket could be more likely to pop out the back. The other thing that's important with the cup position is what we call the version. If you think about your pelvis, the hip sockets do not point straight to the side. They actually point a little bit forward, about 25 degrees, what we call anteverted. So 0 degrees of anteversion would mean the hip socket was pointing directly to the side. 90 degrees of anteversion would mean the hip was pointing straight forward. So we don't want it at 0 and we don't want it at 90. We want it at about 25 degrees or so. And how you would see that on the x-ray is if you look at this x-ray on the top, you can see you're kind of looking straight across that cup, that you're looking kind of directly across the cup, and the front and the back of that cup are sitting right on top of each other. And then if you look at this one, if that ball weren't there, you can see it a little bit easier, but you can almost imagine that it's a little bit oval shaped, that the front and the back aren't perfectly lining up. So this cup, instead of being like that, is actually rotated a little bit forward. That's that anteversion that we're looking for. And the way we do that intraoperatively is through kind of bony landmarks on the inside of the pelvis as we're putting it in. But in people with arthritis, those landmarks can be a little bit distorted, and also the position that their pelvis was in when the surgery was started. But again, you can imagine on a really big patient, the things that we would use to hold them in place can be tough to really hold them perfectly still, and those patients can move and shift and we can end up with a socket that's like that doesn't have any inversion in it and is a little bit too vertical. And that's not a horrible position of the cup, but it is probably off enough that it contributed to that hip popping out of the socket. So we'll talk about how this can help me avoid an x-ray that looks like this one. The other thing that we want to do is we want to avoid complications. So we want to put the pieces and parts in right where we want, but we also want to avoid complications. We don't want people to get blood clots and infections. When we put these pieces in, you can see this is shaped almost like a wedge, and we're putting it in really tight into the femur here. And what we don't want is, as that goes in, if we hit it just a little bit too hard, to split the femur open. That can happen. So we want to try to do what we can to minimize the risk of those sorts of bad things happening. So how do we do it? What are the approaches? The ones I'm going to talk about are these top three: the posterior approach, the direct lateral approach, and the anterior approach. There's also an approach called the anterolateral approach, and one that for a while was really quite popular, but definitely less so now, what's called the two-incision, where doctors were actually making an anterior approach the way I do it, to put the socket in, and a posterior approach to put the stem in the femur. I'm not particularly going to talk about those because neither of those are very common or popular these days, but I'll talk about these top two, which are probably the two most common, and then this anterior approach, which is the one that I do. So the posterior approach, as I mentioned before, it's done with a patient in the lateral position. So they're laying on their side, their pelvis is perpendicular to the floor. We have clamps that kind of hold their pelvis and their body stable in that position. As I said, because we really rely on maintaining that stability of the pelvis to know where their pelvis is in space and to know how we want to angle the cup when we're putting it in place. In order to get in there and to see the hip, we split the gluteus maximus. So that's this muscle right here is the top layer of muscle. And so this picture, this patient's lying at their side, their feet are down here, their head's up here, their belly's here, and their backside's here. So their femur's coming up kind of right here. This is actually the top of the femur there, what we call the greater trochanter. And these little muscles are showing what we call the short external rotators, these SER, short external rotators. So in order to get into the hip joint, the incision's on the side of the hip, we come down through the gluteus maximus, and then we've got to split these short external rotators and divide them off of the proximal femur in order to get into the hip joint. This is the most common approach that's done for total hip arthroplasty, certainly nationwide, almost definitely worldwide. It's been done, a version of this has been done almost ever since hip replacement has been done. It probably started back in the 1970s, so there's a 40-plus year track record of doing it through this approach. The advantages of this approach are it avoids the hip abductors, what we call the gluteus medius. Anybody who's spent time with me or heard me talk in the office about how important that gluteus medius muscle is, that muscle is hugely important for stabilizing the pelvis. Every time you take a step and you're in single leg stance, the center of your body weight is in the middle of your body and you're balanced over on one side on that leg. So if your pelvis were a teeter-totter and it were like this, it would want to tip to the other side. What prevents it from tipping is that gluteus medius, those hip abductors. And so the first surgeon who popularized hip replacement over in England, Dr. John Charnley, his initial approach was actually to cut off the greater trochanter on the top of the femur, flip it out of the way, and that had that gluteus medius attached to it. He'd flip it right out of the way, have a great exposure of the hip joint, put in the hip joint, and then reattach that greater trochanter. That was all well and good, except for the probably 15 to 20% of patients who that greater trochanter didn't heal back down, and they lost that hip abductor. They lost that stability and the ability to kind of do single leg stance without the pelvis tipping out of the way. So this approach was developed to avoid having to go through those hip abductors. It does allow for minimally invasive surgery. So many of you know my partner, Dr. Lightheart. This is the approach that he does. He does it through a very small incision. He does it very minimally invasively. When orthopedic surgeons talk about minimally invasive, it's probably a little bit different than when the lay public talks about minimally invasive. In the lay press, minimally invasive strictly talks about the length of the incision. In our minds, we're talking about what we do to the muscles and the tissues underneath that incision when we're doing it. And so, you know, in the past, 15, 20 years ago, maybe even 10 years ago, this incision would have been much bigger, but more importantly, they would have detached all those muscles off, all those short external rotators come down the posterior part of the femur for several inches and just really stripped lots of muscles off in order to get great exposure. Well, a minimally invasive posterior approach is going to detach fewer of those. And the more of those muscles that we leave attached, kind of the less chance that they're not going to reattach when we sew them back, the quicker that recovery is going to be. And so you can do this posterior approach through a minimally invasive approach. It still does involve detaching some of those muscles, but we can do it through a minimally invasive approach. As I said, established track record. It's been around for a long, long time, almost as long as we've been doing hip replacement. The downsides are, the biggest downside over the years has been the relative increased risk of dislocation when compared to the direct lateral approach, which is the other one that I'm going to talk about. That is because these short external rotators, and especially this muscle called the obturator externus, are very important at helping pull the hip into the socket. So one of those short external rotators, that obturator externus, kind of comes in and it attaches on the bone up here, and it's pulling the hip into the socket. And if you cut that muscle, and then when you reattach it, it doesn't reattach quite as well, there's a little bit less of a pull of that hip back into the socket and increases the risk of dislocation. That risk of dislocation has come down over the years as we have understood the importance of repairing those structures and really being very meticulous about that repair, but there probably is still a slight increased risk of dislocation through a posterior approach as opposed to a direct lateral. The other con is, to some extent as a con, is the need to follow hip precautions. So because those muscles have been detached and repaired, for the first 4 to 6 weeks post-op, there are some restrictions on how much you should move and twist and flex and do those sorts of things, because too much motion in any one of those planes can disrupt those muscular repairs and then potentially lead to instability. The direct lateral approach, this is the approach that I did for my first 5 years here in practice. It's the approach that I learned over at Dartmouth, and some of the Dartmouth docs are still doing it. Some of them are doing the posterior approach, and actually some of them are doing it the direct anterior approach now that I'm going to talk about. But this is how I learned how to do it as a resident over at Dartmouth. It is also done with a patient laying on their side. So feet are down here, heads up here, backside, and belly. And the incision basically comes right down onto that greater trochanter. And what it does, this picture doesn't really show it terribly well, but those hip abductors, or the gluteus medius, kind of come in this direction and insert right onto the greater trochanter. So what you do is you split the front about 1/3, maybe to 1/2, depending on how big the patient is, of that muscle, and then you come down and elevate it off the bone, and you bring all that off. This picture shows that they've taken all the muscle off the bone. We typically don't try to do that. We try to leave the posterior portion of that muscle intact, but it definitely detaches a portion of that insertion of the hip abductors or the gluteus medius. It is the second most common surgical approach right now, and I can't say that I've looked at these numbers specifically, but I would estimate that probably 60% or so of hip replacements are done through the posterior approach. Probably 35% or so are done through a direct lateral, and the anterior approach and some of these other approaches are probably, I would guess, only 5, maybe 10%. And I know that doesn't add up to 100, but it's pretty clearly the second most common approach. Big advantage of this is decreased risk of dislocation, because you're not going through those posterior stabilizing muscles. And I didn't mention kind of the reason those posterior muscles are the most important is because that's the most common position for the hip to dislocate into. So on this picture here, that femoral head is kind of dislocated up and back. And when we think about the hip precautions that people have after surgery, it's no flexion past 90 degrees, no adduction, and internal rotation. So when you're doing that, in the hip, it's no flexion, adduction, and internal rotation, because that's the position that it's going to go and come out the back. So obviously I'm showing if flexion's toward me, this is the front, that's the back. The most common place for that hip to dislocate is going to be out the back. So that direct lateral approach does not violate any of those posterior structures. That posterior stability stays intact. So there is a decreased risk of dislocation. Could be argued that the acetabular exposure is a little bit easier just because of where the femur is relative to the acetabulum. Might be a little bit easier to get that acetabular exposure and get that socket exactly where you want to. It also allows for minimally invasive surgery. As I kind of said, that Dr. Charnley would cut off the whole greater trochanter and that whole abductor insertion. That was a true direct lateral. He would go directly laterally in there, get the bone and the abductors out of the way and go right in. Well, the way I was doing it was definitely more minimally invasive than that, because I was leaving as much of that muscle attached as possible. But the big downside is that you do detach those abductors. And if those don't heal back well and you lose some of that strength, the way that people compensate if that muscle is weak is basically you've got to put your center of weight over your hip. So they end up walking like this and bringing their body weight over that hip in order to avoid their pelvis falling, because otherwise they end up walking like this where their pelvis kind of shoots off to the side because that muscle isn't strong enough to keep it supported. Very well. Thank you very much. A lot of practice. Yeah. From a functional standpoint, a little bit of kind of that, what we call that abductor limp, where people kind of rock to the side. Functionally, it's okay. They don't have pain after the hip replacement, but it certainly doesn't make them happy, and it doesn't make the surgeon happy to see their patient walking down the hallway when they're doing this and they know exactly why they're walking like that. The other downside is you need to protect that repair. So just like with the posterior approach, you have to have those hip precautions, hip restrictions to make sure that that muscle has the best chance possible of healing back down onto the bone where you detached it from. So now the anterior approach. Quite a bit different from either of those other two approaches. Instead of having it done with the patient laying on their side, they're laying on their back. And I'm going to show you, kind of go through this table once I'm done blabbing, and kind of show you how it works or why it works. But the patient's basically laying on this special operating table to improve positioning and exposure. Now, I had to sign all sorts of things for Carol Lilligard saying I wasn't going to talk about any specific commercial entity. You definitely don't need this table or a special table to do this surgery, but I'm going to show you why a table like this makes this surgery kind of a lot easier and a lot more possible. But this table really makes this procedure through this approach able to be done without having to detach any muscles. It is a true internervous and intermuscular approach. So the incision, and that's not really where I make my incision. So here, right there, is what's called the anterior superior iliac spine. So it's that bit of bone that's right on the front of your pelvis. I make my incision 2 centimeters lateral and 1 centimeter distal to that. So I start right about there and make the incision aiming a little bit lateral from that point. So the incision's right there in the front of the hip. And the interval that we go into is between this muscle right here, which is called the tensor fascia lata, and that muscle right there, which is called the sartorius. And so you go right in between those muscles, and then basically right underneath that is the femoral neck. So I open up that interval, go in between those two muscles, push them off to the side, don't detach anything from the bone, and then put a retractor down on the lateral side that's right over the lateral part of the femoral neck. And then I get a retractor on the medial side, which is going to go underneath these muscles, which is going to be basically that sartorius, and then right underneath is this muscle of your quadricep called the rectus femoris. Go right underneath that rectus femoris, and then I'm looking right down at the hip joint, at the hip capsule, without having to detach any muscles. So it's a true intermuscular approach. So the advantages are, number one, the patient is laying flat on their back. So I know that they're flat on their back. I know where their pelvis is. I can tell if their pelvis has moved or rotated because they're laying right there. There's no clamps or anything holding on to it, and I can feel under the drapes and make sure that their pelvis is where I thought it was going to be. It's very easy to use fluoroscopy or x-ray during the surgery. And again, when I bring this table out, you can see that there's nothing underneath where their hip is going to be, so an x-ray machine can come right in. Big one is no splitting or detaching muscles. Another big one, no post-op hip precautions. So because I haven't detached any muscles from the bone, I don't need to protect the healing of any of those. We need to, make sure the patient is comfortable, make sure their pain is under good control, but the healing of the muscles is just recovering from kind of that stretch, or that they kind of get beaten up a little bit just from getting moved out of the way, but they don't have to reattach to the bone. The thing that, and kind of a caveat to that, anytime we're doing any of these, like I said, the bone needs to grow into these little nooks and crannies. Just like a fracture, for kind of bone healing and bone remodeling to occur, that's going to take about 6 weeks for the bone to grow into all these little nooks and crannies. So I tell patients, even though you don't have any precautions on or restrictions on how to move or how you can sleep on your side or bend or twist or any of those sorts of things, you don't want to be doing something too aggressive, splitting wood or stacking a cord of firewood and carrying heavy weights until we're sure that the bone is fully ingrown into those parts. And that's going to be the same regardless of what approach you use. And the other benefit, and I can't say that I can say this with any scientific data other than what I've seen and what others report, but there certainly does seem to be a quicker recovery and a much easier post-op course than what I was used to seeing when I was doing the direct lateral approach. What are the downsides? Well, it requires a special table. This guy cost the hospital probably somewhere between $80,000 and $100,000, so not cheap, but if you look at what the overall hospital charge is for a single total joint replacement, you can do the math and figure out that pretty quickly, it is not cost prohibitive to get something at that cost. Another downside is this is an approach, a way to get into the hip that most surgeons aren't terribly comfortable with, and so you have to kind of learn this new way to get there. And I can tell from my experience that for probably 4 to 6 weeks before the first one of these that I did, I spent a lot of time thinking about it, and the week before I spent probably 2 to 3 hours every day reviewing the approach, looking at my anatomy books, figuring out exactly how to do it and what to do. And anybody from the OR could tell you that I came in with a, 7 or 8 page packet of every single step that was going to be taken from the time that patient came into the pre-op area until the time they got to the recovery room, for everybody, for what I was doing and for what everybody else was doing, to help make sure that I remembered all the steps that I needed to do. So, that I think this is probably the biggest thing that prevents more surgeons from doing it, because doing something that's completely different than something that you already do pretty good already is pretty intimidating. So that's a challenge. There are definitely, and I mentioned this before, that there are certain femur shapes and certain deformities that are not going to really be conducive to using this approach or this implant. And so there are some people who you don't want to do it to do this approach for. So there's a picture of the table. I've got it up here, but we'll talk about that again. Well, maybe I'll move that over now. So when using the C-arm is just a kind of a portable X-ray machine that we can use in the operating room. Is that good? Yeah. Okay. Did I lock it? And I'm going to get in trouble if I break the table. That's probably good. So, so this is basically where the patient is sitting. So they're laying right here. Their groin is right here. We've got this little post to kind of go in between their legs, and then their feet go into these little ski boot things. And these kind of can move front to back. We lock their feet in there, and then we can pull a little traction to get them nice and snug up against the post. But we can bring an x-ray machine that comes in. We call it a C-arm because it's shaped like a C, that can kind of come right in here and take an x-ray of their pelvis. And so I spent a lot of time talking about the importance of putting that socket in the right place and knowing what the alignment of the pelvis is before we put that socket in to know we're putting it in the right spot. So what I do is I bring in that C-arm and get an x-ray of their pelvis, not necessarily of the side of the hip that I'm working on, but of their pelvis, and make sure that the x-ray beam is giving me a true, what we call an AP pelvis, so it's perpendicular to the pelvis. So if that patient, because I've kind of, when I'm doing the acetabular socket, I actually have, if I'm operating on the right leg, I've got their right leg dropped down a little bit. Their pelvis may rotate a little bit on the bed, but I can see that on the C-arm machine and get a true AP image of the pelvis, however much their pelvis is twisted and moved. Once I have that AP image, I'll move it directly over the hip that I'm operating on. And then, I need to hold on to all my stuff here. So then, when I'm trying to look at, and I'll do it on this one because I can just see it easier. When I'm trying to look at the position that socket's in, I can make sure that how vertical, the first part I'm doing it is with the reamer, which is a little, basically it looks like a cheese grater that's a half circle that's shaped just like that socket, that's hollowing out the socket. Make sure that I'm putting that in at the right amount of vertical or horizontalness that I want, as well as that I've rotated it a little bit anteriorly, so I'm looking at that oval shape of the reamer as opposed to just straight across the reamer, to know that I've reamed the socket in the perfect alignment that I want it to be. And then I take that out, and then I put the socket in, and I've got the x-ray right there, and I can see that as that socket's going in, I'm maintaining that optimal position. And so I know when that socket goes in that it's right where I want it to be. And I don't have to wait until the patient gets to the recovery room to get an x-ray and then say, well, it's not perfect, but it is what it is, and we can't really change it now. So we use the C-arm first of all for putting in the socket. And then the other part that I think is hugely important is that, and I didn't talk about this, anytime we do hip replacement, once you cut off the bone at the femoral neck, the only thing that's attaching the femur to the pelvis are muscles and tendons and ligaments. But those things are all stretchy, and so depending on how big of a femoral piece we put in and what size head and what length neck and those sorts of things, we can actually change the position of the femur relative to the pelvis. So the two things that we talk about are leg length and offset. So the offset is the distance in between the pelvis and the femur right there. And then the leg length, basically the way that we test that is we draw a straight line right underneath the bottom of the pelvis and see where that line intersects with this bit of bone, what's called the lesser trochanter. And that tells us the leg length. Well, with this, I don't think I have that on this talk. But basically what I do, let me see if I can find that real quick. Sorry about this. So what I do is I bring the x-ray machine back in, make sure we've got a nice AP pelvis again, and then I take an x-ray of the non-operative hip and make sure that I can see the tip of what we call the greater trochanter there, the lesser troch there, and the pelvis. And then we push the C-arm across to the other side and take a picture of the other hip. And so this piece actually is our trial piece. It's kind of a practice piece. That's the real socket that has gone in, and that shows that anteversion very nicely, where you can see kind of that oval opening of the cup or the socket. And I like how vertical or how horizontal that one is. And basically, after the x-ray tech takes that picture, we print out that image. And then we take this picture and I print out that image. And then I'll actually put a fresh pair of gloves over top of the ones that I've been using and a magic marker, and I'll draw a bunch of lines on this picture. I'll draw this line, what we call the ilioischial line, and I'll draw out this obturator foramen and the iliopectineal line, and then a line around the ischium, and then a line on the femur that goes around that little bump of bone, the lesser troch and the greater troch, and do the same thing on this one. And then I put them up on the view box and I lay them on top of each other. And I can see, have I restored the offset, the space in between the pelvis and the femur? Have I restored that offset? And then I make sure that that little bump of bone overlies that little bump of bone. That tells me how long their leg has been made. Kind of the standard way of doing this, we have kind of measurements that we can do prior to the surgery. We will template and kind of get an idea of what size we expect to use, and that helps us out quite a bit. But really it's more a matter of feel with the standard way, and after you do a lot of them, you get pretty good at it, and you can be pretty close the vast majority of the time. But this allows me to be almost completely certain, unless I'm doing something funny with the x-ray or something's happened that I don't appreciate. This doesn't let me cheat it, and it doesn't make me do it by feel. I actually can verify that leg length and that offset are being fully restored right back the way that they want to. And then so that when I get the x-ray in the recovery room, I always get it and it looks like this, where that socket's right in good position. I like how horizontal that is. It's got the right anteversion of the cup. The space in between the pelvis and the femur is equal on both sides, and the leg length's equal on both sides. And that, just takes some of that potential for error, potential for not putting things exactly where you want them to be, out of the equation. I had put those in this doc. Oh, I did have it. Just needed to go one more slide. Okay. There we go. No wonder I thought it was there, because it was. So, again, and we talked about it, what I've found is the biggest advantage is just how quickly these people are getting better. And they just, the first 5 years that I was here, when I was doing the direct lateral approach, I can remember 2 patients who I had who left the hospital the day after surgery because, people would stay typically 2 days, sometimes 3, just because they were in pain and they were hurting, and it took some time to get used to the precautions and how to get in and out of bed the right way and all those sorts of things. As an example, 3 weeks ago, I did 7 hips in 1 week, which was it was weird. It was a lot more than I ever do. But I did 7 hips in 1 week. 5 of those patients left the next day. Obviously, that's not a scientific number to say that it's different, but it's different. The patients are they're having less pain, they're feeling better sooner, they're coming back to see me for their 1-month visit, and I would say probably 90 to 95% of them at their 1 month postoperative visit are not using any type of assistive device, or maybe they're carrying a cane with them when they're out of the house. But they're just kind of carrying it. And there's still maybe 10% of folks who are limping along and still need their walker and aren't necessarily getting better any faster. But to compare that to, probably the 60 to 70% of patients with a direct lateral approach who at 1 month were still on their walker, I mean, it's like it's a different surgery. So I already did part of this demonstration of the HANA table. The thing, and I said I was going to kind of explain why I think this is such an important way to be able to do this approach minimally invasively and without having to detach any muscles. And it's this little piece right here that's really the key. So I've got their legs in position, but you can imagine to get down into the femur through an incision in the front. Well, the femur's, my femur's right here, and that incision's right there. So it's about, 2 to 3 inches down in me, and I'm not a terribly big guy. You can imagine in bigger people how much deeper that is. And to try to get there and to get down into that femoral canal and around the pelvis is pretty challenging. So what we basically need to do is we need to lift the proximal femur up into the wound so that we can kind of get over the brim of the pelvis and down the femoral canal. So what we do, and this is after we've cut the ball off the head of the femur, of course, is we put this piece all the way down to the ground. And so that really extends the hip. You can imagine if you tried to do this without, with your femur in place to be laying all the way back and to get your leg that far down, it'd break your femoral neck or pop your hip out of the socket. But we've already done that. So that allows us to do that. But then we still want to lift that femur up into the wound. So we've got these two little pieces right here. And basically this little hook slides right underneath the proximal femur and holds it like that, and then it goes into this bracket. So this is going into the wound and then up and out of the wound and on the side of their leg onto that bracket. And then basically I've got this little step here, and you can see that it lifts that up. Now, one thing that if you're actually doing the surgery, you want to make sure, I could just stand on this and let it lift as much as it wants to, but because everything is still attached in there and there are a lot of muscles and tendons and ligaments and all that still attached, you can actually pull it up high enough that you break the femur. So when I'm really doing this on a person, what I do is I actually kind of lift up the leg and I hold it at a spot where I can feel like I can safely lift it, and then I just bring that up to it. So if you ever read one of my operative notes, I will say the hook and bracket were used to prevent the femur from sagging posteriorly into the wound. I don't say that the hook and bracket were used to lift the femur anteriorly, because I'm actually lifting the femur anteriorly myself so that I don't do one of those complications that I talked about earlier where we break the femur. That doesn't make me very happy. So I lift the femur up into the wound in a position that I can see it, and then bring this hook and bracket up there, and then that allows me to do that. And then we've got some other fancy retractors that help hold the kind of the other muscles in the belly and the things out of the way so that we can get down into the femur. But I think that's about it. I think my last picture is just, I didn't need to come over here. But just, that needs to be my last picture every time. But any questions? Yes, sir.
With the old lateral approach, you were saying there's always a little shortening, I think, with your surgery of the extremity. You said you're trying to line things up so that extremities are equal. Is there still any way that you can lengthen somebody's short leg, or
you absolutely can.
Too long a leg?
Yes. Okay, so the question is there a way to lengthen a leg that's too short or shorten a leg that's too long to make the extremities equal? And the answer is yes, kind of with a caveat. We try to really avoid shortening because if we shorten the leg, then the muscles are not at their natural resting length and the muscles are a little bit lax, and that's going to increase the risk of dislocation. So with the standard approach is we would tend to, if anything, lengthen the operative leg, because that would make us feel more comfortable that the hip was more stable. Because if you make this longer and you put a longer neck on it or a longer ball, when we reduce it in the operating room, it takes more of a pull and it really clunks into place. And if you're worried about dislocation, if you've got to pull really hard to get it in, it makes you feel pretty good that it's not going to want to pop out. If you make it too short, it'll just kind of fall in and fall back out. But you can absolutely lengthen somebody if you wish. So I did a surgery on a relatively young guy 6 weeks ago, 2 months ago maybe, and he had a disease as a kid called Perthes disease, where he had kind of collapse of his femoral head. His femoral neck was misshapen, and that leg was probably about 2 centimeters shorter than the other one. I think I got him about 1.5 centimeters of that back in order to equalize it. I was afraid to go any further just because it was getting pretty tight. I didn't want to stretch his sciatic nerve, but you can absolutely change it. I just did a surgery this week on someone who had total hip replacement on his other side and had had that previous by another surgeon, and I didn't feel like that necessarily that offset in leg length were where the one that I was about to operate on was. And so when I did that overlay technique, I knew that I wanted to have more offset and a little bit more length on the side than I was doing than on what he had. So when I did that overlay, I just made sure that I was giving him more offset or more leg length. But, I can still, this approach doesn't guarantee that I'm going to match the leg length and the offset. I've still got to make sure I've got the right size and the right positions and all those sorts of things.
Is there different prosthesis though when you want to lengthen a little bit?
How you
set it in the femur?
It depends on a couple things. It depends on how you set it in the femur. If for instance, if I cut the femur, if I cut the femur at the spot that's on that picture, and when I did my trial reduction with that template in place, I said, man, I need this to be a lot longer than it is. What I could do is I could put in the next size of this, which is actually going to sit up higher, because it's kind of the same shape and the same taper. It just gets bigger at the top. So if I wanted more length, I could go to a bigger size. If I was too long, I could go to a smaller size and have it fit further down in the femur and then just adjust my neck cut. But yeah, there's all sorts of sizes. And then the heads. So these heads, we can have a -2, a 0, a plus, it's -2, +1, +5, +9, +12. And that allows us to gain length. And then we have what we call standard offset and then high offset, which affects the angle of the neck for any of the sizes that we have. Yep, Dr. Weiss?
Yeah, so the patient wants to decide what kind of surgery he or she wants to have. Is there some evidence beyond what you showed? I mean, any randomized kind of trial comparing those different approaches?
Yeah. So the question for the video is, are there any randomized trials comparing the approaches? And the short answer is no. There are definitely some cohort studies. Most of them are comparing like direct lateral and posterior approach, and most of them are retrospective. So, we had 200 patients, 100 of them had a posterior approach, 100 of them had direct lateral. Typically, it was kind of surgeon preference, and what we found was the posterior approach had a couple more dislocations and the direct lateral approach had a couple more people limping. But I'm not aware of any direct comparisons of the anterior approach that have any scientific validity, at least. There's certainly no literature guidance on what's best. Yes?
A lot of people are opting for bilateral total knees these days. Is
Yep.
the day of the bilateral total hip coming?
Yeah. So the question is, a lot of people get bilateral total knees. How about bilateral total hips? In the right patient. I've done one, and again, he left on the day after surgery. He left on post-op day 1, so he was 2 hips that left one day after surgery on this approach compared to 2 for my entire direct lateral. But it's got to be a healthy patient and a fit patient, and to be perfectly honest, kind of a thin patient. You know, the bigger the folks, the harder it is, and the more complex it is for me, and the harder the work, the longer it takes, and the more blood loss. So on somebody like that, it's probably not a great idea to do both at the same time. But this does absolutely open the door for a bilateral hip replacement, because the reason we didn't before is, you can imagine, if you could only flex your hip to 90 degrees post-op, if you had both of your hips done, how do you stand up without flexing past 90 degrees with one of them? So if you have one done, you put that operative hip out in front, so you keep it like that. If you had both of them done, unless you're really strong and can kind of push yourself up for the first 6 weeks, it's really not feasible to maintain your hip precautions for a full 6 weeks. But I'm a big believer in bilateral total knees, and in the right person, I think I'm now going to be a believer in bilateral total hips if they need it, and if they're, you know, a candidate for it. Anyone else? Yes.
Why are there different size screws that go up into the acetabulum?
Yes.
And why?
Because, so if I put, where's my pointer? So the question is, are there different length screws for the screws that are going up into the acetabulum? And if so, why? So that screw is going right up into the ilium, full of bone. That screw could probably have even been another inch longer. If that screw is put in this direction, and you put in a screw that long, it would be sitting right in the middle of the pelvis. So, you know, for all of our implants, you know, for fractures and stuff like that, we use the right length screw to fit within the bone in the angle that it's going. And because the pelvis is a pretty complex 3-dimensional shape, even with this table and the C-arm, sometimes my screws, you know, are ending up right here, and sometimes they're up here. So if they're right here, I'll put in a 25 millimeter screw or a 20 millimeter screw, and if it's up here, I'll put in a 40. And I'm just going to put in whatever length is the right length to make sure that the tip of the screw is still in the bone or only a little bit out of the bone. All right, well, if you have any questions, don't hesitate to give me a holler. I actually have a video that in the past I've shown, but I had to sign all sorts of waivers saying that I wasn't going to promote any commercial entity, and the video I have was made by a commercial entity, so I decided to just talk the whole time instead of showing a video. And if anybody would like to observe surgery, we've definitely had people and nurses and therapists come in and observe surgery, and always happy to have visitors, so let me know. Thank you very much.